Thank you. Can everybody hear me back there? If not, we can just take off the mic and I'll start screaming. So we are going to talk about restless legs, and you'll understand the title a little bit after we get into this. The big objectives here is understand these diagnostic criteria, which is points towards this urge piece of the puzzle. Look for the common causes and pitfalls that isn't just idiopathic restless leg syndrome, and then outline some of the available treatments, a treatment algorithm, and some issues that we have with some of our current treatment options. So Willis-Ekbom disease is actually the given name of restless legs. We've gotten away from, eponyms for things. And so restless leg syndrome was originally described by Willis, designated a clinical entity by Ekbom. And you can see that happened about 300 years apart. It's a clinical diagnosis. It has nothing to do with lab work and testing. And the only way to truly make a diagnosis of restless legs is in the clinic setting. And it's oftentimes, there's a lot of people that talk about the relation to periodic limb movements of sleep. And interestingly enough, that's not a one-to-one thing. So when we do a sleep study and we're looking at the results of that testing, periodic limb movements on the sleep study do not equal that person is going to have waking symptoms of restless legs or vice versa. So Thomas Willis's description it was translated in 1685, symptoms vulgarly accounted for hysterical, or secondly, the spirits being called from their watchings and converted to the genus nervosum, sometimes transfer their sallies into the spinal marrow, and thence into the nerves that pass to all the outward members, your extremities, where to some, when being abed, they betake themselves to sleep, presently in the arms and legs, leapings and contractions of the tendons, so great a restlessness and tossings of their members ensue, that the diseased are no more able to sleep, and then if they were in the place of the greatest torture. That is a fantastic description of restless leg syndrome. So what is not restless legs? Toe tapping, leg bouncing, leg movements during sleep, that's periodic limb movements or myoclonic jerks. Nocturnal leg cramps is a whole separate diagnostic entity. Leg movements that predominantly or exclusively happen during the daytime hours, and any arm symptoms and less severe restless legs and or years of medication usage. Toe tapping, leg bouncing. My wife's a psychiatrist, and one of the things she talks about is a lot of people get strapped with the diagnosis of bipolar disorder. And bipolar disorder is not mood swings. And that's what a person will come in and tell you, oh, I got mood swings. They told me I have bipolar disorder. That is not the diagnosis of bipolar. The same thing happens with restless legs. Somebody comes in and says, you know, when I sit at my desk, I have to bounce my leg or I have to tap my toe. That's why I have restless legs. That is not the same thing as restless leg syndrome. So what is it? Now, here's the diagnostic criteria. And again, it's a clinical diagnosis that requires the patient to describe all four of these symptoms: an unpleasant sensation or urge to move the legs. I've heard all sorts of descriptions: cramping, crawling, creeping, pulling, throbbing, aching, itching, electrical sensation. And it's typically deep. It's not something on the surface, it's in the calves, and it is usually at least somewhere should be ascribed between the ankle and the knee. Typically, it's not pins and needles. That is more the neuropathic type change that we see. R in urge is it's made worse with rest. You sit down in the evening to watch television, you lay down at night to go to bed, and that's when the symptoms really crop up. These people describe, I sit down and watch my favorite show and I have to walk around the living room to watch it because it's just so uncomfortable for me to sit. G, this is a little bit more of a stretch, but getting up and going makes it better. So moving around makes it better. Massaging it, stretching it. These people are up all night long, walking every few hours, because every time they wake up, they can have these symptoms come back as they try to go back to sleep. And they always should start in the evening. Evening time should always make it worse. They tend to report that if they get sleep the early morning hours, they're much better, and then they're symptom free upon waking. So you can see there the urge, and then all of them. So I have a few of these little charts in here that are nice for clinical usage. Other factors affecting who gets it, the big one is genetics. This does seem to run in families, although we don't have specific genes that we're on the lookout for. Twins tend to have it commonly, family history 40 to 60%, and there tends to be a flavor of an autosomal dominant pattern if they do pedigrees. Gender, women tend to have higher rates than men, and that may have something to do with something we'll talk about later. And then ethnicity tends to be Northern Europeans much more so than Germanics, Mediterraneans, and then it's rare in East Asia and Africa. Consequences, they also, not only do they have to describe the symptoms, they need to also describe that there's some effect on their sleep or their function because of it. It actually really requires both. So they need to have some trouble initiating their sleep, having wakenings, especially early in the night, that they're depressed from it, or that they have changes in their daytime functioning. Moderate RLS really only takes symptoms 1 to 2 times a week. This doesn't need to happen every night to be a problem for patients, and it disrupts their daytime functioning. Severe is greater than 2 times per week, and it interrupts their sleep and impairs their daytime functioning. There is a scale. It is impossible to read. Oops, sorry about that. It is impossible to read over there. This scale, the IRLSRS, is similar to what we use our Epworth for, except for the Epworth is much easier to administer in the clinic setting. This oftentimes you have to hand to patients, and it gives them a flavor of how severe or how much effect it has. This is more something I would use if we have tried a multitude of interventions that have been unsuccessful. Where are we missing the target at in terms of helping these patients out? It is similar to, I know we had a thing with the mini mental recently. This is actually a copyrighted test, so we don't use it all that often. What causes it? We don't know. Like most of things, we don't have any idea. The working hypothesis is that there's a dopamine deficiency versus a dopamine dysfunction, and it kind of goes back and forth. The dopamine deficiency would explain why a dopamine agonist can be beneficial, and it would also explain why iron deficiency has a role as it acts as a cofactor in that conversion of tyrosine. It also acts to inhibit the spinal cord pathways in the anterior horn cells and for these movements at night, and serotonin is strongly excitatory in that pathway, which is why SSRIs tend to be a problem in restless leg. So why are the pathways important? The biggest one is iron deficiency, and this is one thing that I've probably seen at least a dozen people since I've been here that we have fully fixed the restless legs solely with iron, checking their iron studies and actually just replacing their iron. Reduced central iron stores is the most consistent finding that we in RLS. So even if your systemic iron is normal, and there's no way to get at that central store, so we have to kind of go based on what the patient's experiencing and what they've benefited from and haven't benefited from. Low peripheral iron, though, is a marker of a more significant central deficiency, and as such, supplementing it tends to increase the central store and thereby make it better. Low ferritin is the best indicator. It's complicated because we see ferritin be elevated in the setting of any sort of acute inflammation, things like that, and it actually can mask what is truly a low set point for their ferritin. I actually just saw somebody last couple days, their ferritin over the years had been 12, 13, 175, 42, 23. Well, in the setting of 175, they'd been sick, but in reality, their ferritin naturally hangs at a low point, and they were dealing a lot with their restless leg type symptoms. Levels less than 50 tend to correlate strongly. We actually are usually targeting, this will come up again, a level above 50, even a level above 75. We try to get the supplementation up to. Uremia also sees a lot of RLS associated, and it has to do again with a coexistent anemia, some iron deficiency. This group of people doesn't have that strong family predilection for having RLS. So in isolation, uremia as the source, you don't expect that family history to be there. Correction of uremia tends to improve it if you use transplant to improve the uremia. If you just do dialysis, it doesn't actually improve the restless leg symptoms. Other big ones, the ongoing treatment for depression with the SSRI, SNRI, TCAs. That serotonin, as we talked about, is a real problem for the spinal sympathetic pathway. And the only antidepressant that we've seen that doesn't have this effect is bupropion. And so when I see a patient and we go over their med list and I talk with them about that their SSRI or their SNRI could be causing this trouble, we have to balance out whether or not we think they're going to benefit more from being put onto an additional medication versus being off of their SSRI. I have had 2 patients at the university that had such severe symptoms, we would take them off, and when we took them off, they're actively suicidal, and so you have to deal with the fallout of being on the SSRI because it's the only way to keep their mental health in check. That is quite difficult. We'll get to a chart that can help us with some of those decisions, but you have to really, in those situations, look for every possible underlying cause, whether it be iron, whether it be uremia, whether it be something else. And if it shakes out that the SSRI is the problem, you just have to balance out what you can and can't do for the patient. Dopamine blocking agents, antipsychotics, this one makes obvious sense. If the dopamine can't get to the receptor, you're going to have problems with the restless legs. Diphenhydramine, which we use as over-the-counter sleep aid quite frequently, can also cause problems, as can anti-nausea medicines along the same route as the dopamine blocking agents. Caffeine, alcohol consumption contribute as well. Tends to be that towards the evening time hours, that tends to be more of a problem than if they're drinking caffeine during the daytime. Other conditions that have an increased prevalence include things like your neuropathy. It's typically the axonal types, not the demyelinating, spinal cord diseases. Pregnancy, this actually really crops up in the 3rd trimester and then gets better right after delivery. MS, and then Parkinson's disease. This is a big thing. I have a lot of patients come in, you put them on a Parkinson's disease drug, and their question inevitably is, am I going to get Parkinson's disease? There is no evidence that exists that there is a link between RLS and Parkinson's disease. These are 2 separate entities. My statement to them, my canned statement is, while you have restless legs, this doesn't preclude you from getting Parkinson's disease, but these 2 things would not be related. Conservative measures. Conservative measures alone can be quite helpful for people, especially people that have that moderate 1 to 2 times per week kind of level. Pre-sleep stretches, I have patients who do this, compression stockings, and SCDs. My RLS patients love being in the hospital because the SCDs that get put on them when they're in the bed make their restless legs so much better. This is actually a chart of symptom-based scoring after SCD therapy. And so RLS severity on a 40-point scale, 24 down to 8 after treatment. Epworth goes down. So they are actually better able to function with SCDs. Now, I don't think you're going to get any insurance company to approve SCDs for a patient, but they do work. Biggest thing, the first thing I do is look back through the chart. If the irons haven't been tested in 6 years, you need to test the iron. The iron is a easy fix. It's easy to supplement. It's over the counter, and it's not a medication that's going to have a lot of big side effects. Now, there are some, obviously. Ferritin's less than 50, supplementation is a must. If the ferritin's normal, then I check the iron saturation. That usually comes with the iron studies. Our normal range on our iron, I think, is like 15 is the low point. Anything below 20 is associated with some level of restless legs at times. So we really do try to get that iron sat up too. Iron supplementation initially starts with 325 milligrams of ferrous sulfate or 65 milligrams of elemental iron plus 100 milligrams of vitamin C. I usually just tell them to take it with a cup of orange juice, and it should be done on an empty stomach. I typically start daily and recheck it in 3 months. So this is an efficacy study that was done for the different types of drug therapies available to providers, and this was done in 2007. And the big thing is it starts with the iron, and if you look, if they're iron deficient, it's 70% effective. I mean, it really does do a good job in correcting these patients' symptoms. Then they did outline, and I will be the first to admit that the Mirapex and the Requip people did an excellent job with marketing, because 90% effective. They marketed it to the primary care world. Primary care was able to use it. Their patients got better. And at that time, we didn't know all the fallout. It used to be all we had to worry about was, are they pathologically gambling? Are they having sex with strangers? We got to stop them from doing those things. But it works for the restless legs. What we found, though, is that it doesn't work as well as we thought it did. Some other things that come up down here involve the opiates, and we'll get to talking about those a little bit too. So in the sleep world, we've actually changed. The dopamine agonists are not the primary therapy anymore. Alpha-2 delta ligands like gabapentin, long-acting gabapentin or Horizon, and pregabalin are really the best things to start for these patients. In fact, my training, and we'll get to what the information available to providers is versus my training, but my training was that if a person came in and was having problems with their dopamine agonists, you just took them off and put them on an alpha-2 delta ligand. I mean, you just had to see if the medication was causing some of the problem. Gabapentin, usually, they talk about dividing it up to 3 times a day. For the most part, I start at bedtime only. I start with 600 milligrams at bedtime. We can get up to 900 milligrams at bedtime. These patients tend to do better. It talks about taking it 2 hours before bedtime. I feel that that leads the patient to present back with saying, well, I think I'm taking it too early. It doesn't really take care of the symptoms. It's also, if we go back here, from an effectiveness standpoint, gabapentin is not overly effective according to this study. Now, I've had plenty of patients that are taking it that do very well with it. Gabapentin incarbil, this tends to be if you are having patients that have a problem taking it multiple times per day. It's a single dose, it's given at dinner time, and it's only one value of dosage, 600 milligrams, that's it. There's no 300, there's no 900. I have seen studies out there that show people getting more, but 600 milligrams is the dose. It's hard to get approved without having tried the gabapentin. It's also hard to get approved even if you have tried the gabapentin at times. Lyrica or pregabalin also can be quite effective. There's a lot of crossover between it and gabapentin, so I don't see much difference there. Biggest side effects, somnolence. Obviously, that's a desire. We want patients to be able to sleep. Dizziness, edema, and worsening depression, which comes into play when we start talking about SSRIs and how to offset some of their treatment. Dopamine agonists. So Nupro patch, rotigotine, is actually quite effective, and patients tend to like it. It is a bit hard to get approved, but it is the only dopamine agonist that's considered first line, as it has less of an augmentation side effect than pramipexole and ropinirole do. The evidence suggests that they're all level A to some extent, although ropinirole is a level B for restless legs. And again, you take the pramipexole, ropinirole, you take 2 hours before bedtime, and a rotigotine you just take once a day, or you put on the patch once a day. Biggest side effects, like I said before, used to be just the impulse control disorders. You had a lot of, the big lawsuit was a lady, older lady who had gone to the casino and gambled away their family farm and ended up suing the company, and they found out that this was a problem soon after it came on the market. The bigger problem we're having with it now, though, is augmentation. So what is augmentation? It's actually a complication of long-term dopamine therapy that leads to worsening symptoms. So it may help these patients early on, the first 3 to 5 years, and then these patients get worse. They start to have spread to other parts of their body, including the torso and arms. Restless torso is incredibly odd. And then they have shortened action of the med and increased intensity of the symptoms. These patients say, I took my medicine. It seemed to be getting better initially. Then after a couple hours, I was so much worse than I was before. Anywhere from 2 to 10 years is really the kind of working amount of time that we expect to see this come on. And it's actually increased the higher you pump up their doses. So what we see is that these doses tend to get pushed because they're having symptoms. Well, they're getting pushed in the setting of having symptoms, they're likely having some augmentation, and if the iron hasn't been checked, that tends to make the symptoms worse as well. Has been seen with tramadol, but not with the gabapentins, gabapentin carbils, and the pregabalins of the world. And like I mentioned, a little bit less with the Nupro patch than it is with the other dopamine agonists. So here's a list of kind of the questions to ask to see if those symptoms are appearing earlier in the day. Needing higher doses for control, has the intensity worsened since you started the meds, and have the symptoms spread to the other parts of the body. If the patient describes the symptoms spreading to the other parts of the body, you know you have augmentation. There's really no big ways other than that. There can be a progression of the disease, but I find it far less likely than patient having been on their agonists for 3 to 5 years and it fits the time frame correctly. The important part is if you do think that they're spreading, they're getting worse, is to look for those exacerbating factors, look for the SSRIs, look for the iron issues to try to improve some of these symptoms. There is a very long and very detailed algorithm on UpToDate, I will tell you all, about managing augmentation. That's why I say that the actual hands-on augmentation management is quite extensive, but that's why my training was just take them off their agonist, put them onto their gabapentin and see how they do. You need about a 6-week real clean out to know what you're doing in that term, but it is tough to follow along with this algorithm otherwise. When you get down here to the bottom, however, so all this, and then down here is your long-acting opioid medication. So there is an outcome that does end with putting a patient on an opiate. And I have 3 patients right now that they're on opiates, and we'll talk a little bit more, there we go, about our opioids. So it's only for severe and refractory. Avoid any history of substance abuse, must have a regular review of their PMP, a med agreement in place, and it really should only take a fairly low dose for control. My patients that are on it, I have one on oxycodone and I have a high potency, and then the other 2 are on codeine. I mean, just a low dose of codeine keeps them under control. These patients will have been through the ringer to try things, and usually they'll try all the medicines twice. They'll switched on, they'll switched off. They've been seen by usually a tertiary treatment team. 2 of the 3 patients I have here actually transferred with me from the university that I had seen there as a fellow, and because they were closer to Ames instead of driving all the way to Iowa City. So we see them now here. It's hard. I mean, in today's day and age, you have to just keep following up and make sure that they're getting the opioids on the correct schedule. Try to ask them to abstain from caffeine, alcohol, try combination therapies, lifestyle modifications. One of these patients actually, until she got onto codeine, worked doubles. She worked at the casino in Tama, and she worked doubles because she couldn't sleep at night until she was just so exhausted. She was making a ton of money working, but she couldn't sleep. She can now sleep and is on a fairly normal work shift. So here's a summary of a lot of these interventions. And again, when we talk about dosing and things along those lines, the biggest thing that I would say to take away from that is always check that iron and know whether or not a patient is iron deficient or is prone to being iron deficient. And that comes up when we talk about why women have it more than men, and that the menstrual cycle tends to play a role. I have a lot of patients who present and initially say that they only have symptoms around their menstrual cycle. Other things that can be helpful for these patients, again, I'd like to say that we're going to get away from Requip and Mirapex as the first line agents. I don't think that's going to happen because they're very effective. They're very effective, but they do lead to problems in these patients. Levodopa on here, and that's the one that kind of is, there's some variation in what people see with it. If we go back over here to this one. So effectiveness of levodopa, 38 to 90%. It is wide ranging. And you would think that giving somebody a dopamine analog would be very effective based on the fact that dopamine agonists work. And there's just no data out there that suggests that that's true. Level C, I mean, it's really very low on what the effectiveness is for patients on levodopa. I've tried it on patients. I've tried it on patients, especially if we're getting to the point of trying opiates on them, and it's just not, it's really very, very limited effectiveness. So how do we choose? Like anything, you have to consider the comorbidities. You have to stick to the first line of agents as much as possible, and you got to monitor for side effects if you're going to use dopamine agonists. The biggest one being the augmentation or the impulse control issues. Augmentation is a real problem, and it's something we didn't know about until, again, these medications had been on the market for 5 years or so. So here's a great chart, and I hadn't actually used this chart, but this is something that I'm going to be looking more towards, trying to figure out what factor impacts what's been going on, and then try to decide where the treatment option should lie. And so when this comes down to the comorbid depression down here, and we talk about, you know, getting them off of SSRIs that could be making it worse. Well, as we talked about, the alpha-2 delta ligands can worsen your depression. And so that first line therapy is probably a dopamine agonist. You end up with issues of hepatic impairment, and you want to avoid requip and use caution with the patch. So there's a lot of guidance based on what the patient's presenting with. I like, because of the comorbid insomnia, that's one reason we end up with a lot of gabapentin used for the legs, because of it does help people go to sleep, and you can get a dose point that really is effective for people. I've had to take people off of their alpha-2 delta ligands because of renal function issues, but understanding, of course, the impaired renal function, the uremia could worsen their symptoms. So you have to come up with a plan that will work for these patients. The painful piece of it, again, along the lines of the neuropathic pain is not the same as the restless leg type pains, but we do use the alpha-2 delta ligands because the pain component that we can get benefit from. So what's the prognosis? Unfortunately, it's a lifelong condition once it's diagnosed, and we're seeing it diagnosed in younger people quite frequently. Teenagers tend to have it crop up a lot, and it's they call it either growing pains, or they get improperly diagnosed with like Osgood-Schlatter's, and in reality, they're having RLS type symptoms. And these patients will deal with this all their life. It tends to worsen as you get older because you've tried meds, and it is a progressive degenerative condition. We're able to minimize symptoms as long as you can try to follow closely some of those aggravating factors, again, whether or not they have depression, whether or not they're managed with an SSRI, trying to ask them to limit their alcohol usage, and augmentation, and making sure we're checking those iron studies. No indication, again, no indication that Parkinson's disease is a resultant of restless leg syndrome. So, all right, those are actually pretty quick today. Here actually is that whole thing I read earlier in the London Practice of Physics. So this is Willis's description, and they had a real problem with S's. Everything looks like an F. Any questions? Yeah. Mm-hmm. No, you'll have to taper it off. It depends on. Yeah, it's every few days usually. Yeah, it's varies by medicine, but it is usually every few days, and you can back off. It's usually bigger amounts early, and then as you get closer to the end, similar to like prednisone, you have to just take them off little by little. So you have to take them off a little bit slower at the end. Oh, sorry. The question was, if you have a person on the medication that you want to get off of them, can you just cold turkey their dopamine agonist, or do you have to taper them off of it? You need to taper them off of it. It's a little bit quicker initially to do. You can do it every few days, removing bigger doses, but towards the end, you have to cut it down by even smaller doses. it was a.
I don't know. This is so smart. I
Yeah.
feel like I've never heard of that.
Which one?
In my life.
Augmentation.
The augmentation.
Yes.
So, yes. So how common, like how vigilant should I be about that? And I'm thinking of one patient who I just actually increased her frequency.
Yeah.
She said she felt better, so.
It's more something to monitor. If they've been on it, if you just started them on it 6 months ago, it's not augmentation. They're just having symptoms that aren't covered. If they've been on these drugs for years and they are suddenly needing an increase in their dose or increase earlier daytime dosing is the big thing. They start talking about, initially they start saying they're having symptoms at dinner time when they sit down to dinner, or they're having symptoms in the late afternoon when they're sitting at their desk. They start to steadily increase. They don't usually present initially with this arm wants to go too. It's usually more the earlier and earlier part. I mean, it really is, it is, you would think a person's dyskinetic when they're in there with restless torso, but they can't stop moving their torso. It really is a problem. So I think it's more of a time frame, understanding the time frame, have they been on it? And then the other piece of it is understanding what the things they're telling you. You know, I take it at bedtime, but it certainly seems to be cropping up earlier and earlier in the evening or in the afternoon. I mean, those are the big ones to start looking, or if they're just needing increasing doses, and then they say, you know, it isn't lasting as long. It's I get it, it works, but then 2 hours later, the symptoms are worse than they were 2 hours before. That's a pretty good indication that they're augmenting.
Okay, so someone who comes in and follow up, like, Dr. Allen, this is making my life so much better, and she's just sitting still until see her again.
Yeah, yeah. An almost perfect presentation then.